So today we'll be discussing the cardiac arrhythmias, in fact the part 2, and we'll be discussing what's called as the heart block. Importance of heart block is that it is patient will come with a chest pain. You take the ECG and then it is your call that what exactly are you supposed to do. So that's why in that ECG you'll find why I'm giving so much importance to this, that there will be very small changes, very subtle changes, right? Very clear changes in every condition, very clear changes. But it should be crystal clear in your mind, and then you'll be able to identify that what we are dealing with. Importance of it is in the treatment, because treatment would change considerably. In one of the case, you'll say that no worries, you go home, take rest, everything will be fine. In second case, you'll be telling that you get admitted immediately. But in one case, atropine will be like a lifesaver. In other case, if you give atropine, then that patient will be going into the worst stage. Right? So that's the reason that it is very clear that we should really be able to differentiate between all these conditions. All right, it is 5:32. Let's start. Okay, so our today's topic, right, we start from here. It will be dealing with atria. Right? So this part you already know that this is the SA node, and from SA node there goes the AV node. Right? SA node is our primary pacemaker. And from here, the Buckman's bundle, which goes to the left atrium, and then from here, there goes one bundle, which is going for the right atrium, and they work. SA node to AV node. AV node is the only window by which the upper heart is communicating with the lower heart. In other words, the signals which are into the upper heart, they will be going into the lower heart. Over here, this is all fibrous capsule, and they are absolute insulator, so no signal can really pass through these. Right? So this is the only electrical window. This much is the foundation. And when we say that tachycardia, atrial tachycardia, that means we are dealing with left atrium, right atrium, and they are beating at a faster rate. So when it is 125 to 250, we say that it is tachycardia. When it is 250 to 300, it is atrial flutter, and more than 350, it is atrial fibrillation. Flutter and fibrillation, they are independent topic in themselves. So that's why right now we are not touching it. Right now, we are just dealing with this system. Correct? Yes, good evening. So when we say SA node to AV node, right, and we said that this is a junction, correct? AV node is a junction. And this is the reason that when we'll be talking about this junction, so anything which is related to that junction, it will be called as junctional, right? Junctional. AV node is the slowest. AV node is slowest because it is giving us the time to fill up the left ventricle and the right ventricle. Right? So that's why when in the ECG we'll see that P wave, and then the time passes. This is the thing. This is the point where it is actually filling up, and then the left ventricle, right ventricle, they contract, and we get that this QRS complex. Right? So that's the whole idea. The problem is occurring into this junctional node, that is the AV node. So either AV node, something is happening that it is going for the higher rate, so tachyarrhythmia, or it is going for the bradyarrhythmia. So simply increasing speed or decreasing speed. So far, easy. We understood that why it really happens that AV node is slowest. What is something that it makes it the slowest one? One is the electric reason. Right? The electric reason. Electric reason is what? The resting membrane potential is minus 60 millimeter. Now we saw over here. Here it is. Here it is a graph. Right? There are AV SA node and AV node. They are electronic. Right? There are no moving parts. So that's why there won't be anything like plateau, because it is in plateau. Plateau is when there is a contraction, right? That is where that small amount of calcium which gets inside, it triggers endoplasmic reticulum, which leads to calcium-induced calcium release, CICR, right? And that leads to contraction of the muscles. But over here, this is out of question. There is no contraction of muscles. We are dealing with only SA node, AV node, that is the electronic system. So that's why leaky channels, right? So over here, this is the sodium, and then when it reaches to a threshold potential, there would be opening of the voltage gated calcium channels. At that specific voltage, calcium channels open and the calcium gushes in. Now this calcium is positive, correct? So if there is strong negativity inside, that means if there are two sets, right? One is minus 90, inside is minus 90, another is minus 60. Calcium channels open. Calcium channels, they are channels, they are not pumps. Pump is something against anything, it just puts it. Calcium channels means these are the gates. Those gates, they open. Now, at what speed the calcium which is outside should really enter in? Calcium is positive, right? Calcium is positive. If inside is more negative, then they will be attracted with a power, with a thrust, because it is more negative, right? So that's why it will be conducting a bit faster. So these spikes, they will be bigger and faster. That's what really happens in case of Purkinje fibers. So in Purkinje fiber, resting membrane potential is minus 90 millivolt, while in case of AV node, it is minus 60 millivolt. So that's why calciums will come, but relatively, means definitely they are faster, but relatively slower as compared to Purkinje fibers. Here, everything is related, correct? Everything is related. Okay, and remember, all these things what we are learning, even at a normal heart rate, it is happening in 0.8 second. In 0.8 second, all the things are occurring, right? From the SA node to AV node to all this bundle of phase, all right left bundles to Purkinje fibers, they contract, blood is thrown out, again new blood is filled in, and then that's it. This entire stage, right, it is completed, it fits in this 0.8 second. When the heart rate is normal, when the heart rate crosses 120, this happens in half a second. Right? Every half a second, this thing is happening. So we are dealing with the electronic system. Right now, we are not talking about the first and the second heart sound. Right? There was an email about it, that where do we put first and second heart sound? Well, it is not that complicated. Heart sounds, they occur when the valves shut. Valves shut, right? So think of when the mitral valve would shut, mitral valve would start shutting when it has completed the filling phase, and then as the blood tries to go back and the valve is closed, because the function of mitral valve is not to allow the blood from left ventricle to left atrium. So as soon as the left ventricle is filled up and the blood tries and left ventricle starts contracting, the blood will try to go up while it's shut, first heart sound. So that means that first heart sound, when we really draw, when we draw, it should really occur somewhere over here, correct? Right now, we are not doing it just to avoid the complexity. I don't want to mix those things. Finally, our final lecture would be what? That would be when we'll be mixing on one page. On one page, there would be systole, diastole, first heart sound, second heart sound, third, fourth heart sound. Right? There are four heart sounds. Then gallops, murmurs. Then all these electronic activities, everything, jugular venous pulse, everything would be displayed. All the left atrial pressure, everything would be displayed on one page with a correlation. Right? There will be. It is the most complex. But if you have understood this thing in a stepwise manner, you'll be able to understand it in seconds. So right now, I'm not mixing just because of that. This is the first heart sound. Right? This is where it occurs. Okay, so coming back to this. So we understood that electronic system is there because minus 60 and the minus 90 millivolt. The second important thing, which is based on histology. In histology, two things occur in any of the pacemaker. One, the gap junction. What are gap junctions? So these are the cells. These are the cells. And in between, this is, you can see they are like windows. Right? So through that window, over here, on one side, so this would be the SA node, right? The signals are coming from SA node. So over here, that sodium which comes, right? It stimulates, and through this window, those sodiums, they keep on traveling. So that in like a wave, right, it would be stimulating. But the point is, in case of AV node, there are less gap junction, right? I'll write it like this clearly, less gap junctions. When it comes to Purkinje fiber, see, number of gap junctions increase. So number of electrolytes, number of sodiums which will be traveling, they will be in higher number. So it is but obvious that they will be acting much faster. And second, the size of the cells, they are relatively very small. So the entire process, right, the entire process of depolarization, repolarization, and then things going into the gap junction, and then once again the whole cycle, that has to be repeated several times as compared to Purkinje fibers, which are the fastest. Purkinje fiber, they are the fastest, in which it has to occur only few times. Because the cells are bigger, they are longitudinal cells. So once the wave has entered, so all the way that cellular activity, it has to occur only once. Number of gap junctions are more, so again it goes to the next cell very fast and the process continues. So that's the reason that they both have got the different speed. But yes, there is importance of it, because AV node, we really want it slow so that there is better filling. And in Purkinje fibers, everything is finalized. Now that it is time for the ventricle to contract. So why to waste time? So that's why Purkinje fibers, they are the fastest. This took us to this level. And that's the topic for today, what is called as the heart block or the junctional block or the AV block. Right? All are the same names. And this thing can be understood by ECG. So this much now you know it very well, because this thing will be using again and again so many times. And that is that whenever the heart rate is to be calculated, so we can take any of the any of the common wave, right? We can take P to P, right? We can take P to P, that is also fine. But R is easy, that's why we are picking up R. Otherwise, any of the consecutive wave that can be taken. We find out that how many squares are there, right? We are dealing with right now big square. So this is one big square, this is second, the third one, and then 3 boxes are here and 2 boxes are here. So it is like 1, 2, 3, 4. 4 big boxes, right? 4 big boxes. And because paper moves at the speed of, we wrote it somewhere over here. Okay. The paper moves at the speed of 25 millimeter per second, correct? And this big box is 5 millimeter. So that means there will be movement of 5 such boxes per second, right? 5 such boxes. So 5 boxes per second, right? Per second. That's the speed at which. So in 1 minute, 300 boxes, right? 60 into 5, so 300. So when we want to find out how many beats, so 300 divided by big box, that's what we have written over here. 300 divided by big box, so it comes to 75. So that's the heart rate. If you want to be more accurate, what you will do, you will say use this formula, 1500 upon RR, but small boxes. Why 1500? Because every big box is comprising of 5 small boxes. So that way you can be very accurate that exactly what's the heart rate. All you need to remember, this is 300 by the big box, and the 1500 by big box, right? So that's how we take the heart rate. Okay, now let's start with our today's discussion. So today we'll be talking about the heart block. Three types. Type 1, they are called as the type. So it is called as the type 1, type 2, and the type 3. As you must have guessed, as we go from type 1 to type 3, it becomes more and more severe. You are 100% right. Type 2 is once again divided into 2 types. One, what is called as the Vankeback. and second one is called as the Hay. These are the two. They are the name of the scientist. So we'll be dealing with 1, 2, 3, and 4. 4 different type of patterns are to be identified. Today we'll be taking the clinical part also. So you'll know that yes, what is really happening in this particular case. So let's start with type 1. Right? We start with type 1 AV block. Right? Type 1 AV block, and that's why it is also called as a type 1 junctional block or type 1 heart block. All are same. Now here, one concept would come, a very, very important concept. The thing what is called as the PR interval. PR interval. The normal PR interval is always less than 200 milliseconds. Now, the moment we say 200 milliseconds, so this means how much? This is one big box, correct? One big box. Because 5 big boxes per second, correct? So one big box will need 0.2 second. 0.2 second is millisecond is 1000 part. So that's why if you convert it, so it will be 200 millisecond. Or you can remember it like 0.2 second is one and the same thing, or one big box. Now let's go to that ECG to understand this concept, because this is slightly misnomer. Misnomer means what is mentioned PR, actually it is not PR. Right? So you just see that, and I'll tell you the reason also that why it is. Okay, I'll just zoom this thing. I'm erasing it. So, because we have already understood it. There are 2 important points to be seen. This is what, this is Q. This is what, this is R. This is S. This is okay, this is P wave. When we are to calculate PR interval, the PR interval is this. You will say that this is the, if you calculate this, so then this is the PQ interval, correct? It is PQ interval. Yes, actually it is PQ interval, but it is said PR interval. Reason? Many times Q is not present. Q is present. Why the Q is present? Because of that interventricular septum. We have talked about this, but okay, I'll briefly tell you that when we draw our heart, our classical heart, right? We draw our heart. So this portion, I just make it bit thick. In reality, also it is pretty thick. That's the reason it is divided into 2 parts, right? Anterior 2/3 and the posterior 1/3, and that's how the blood supply and everything goes. Okay, so this is the left ventricle, this is the right ventricle, and this is our interventricular septum. Now, in interventricular septum, when we say that why there is positive deflection or negative deflection, it simply understands this is the principle of electronics. It has got nothing to do with left ventricle, right ventricle, nothing. Everything whatsoever is happening because of the electronic principle. If the current is coming towards electrode, positive deflection. If the current is going away, negative deflection. What if the current is into this direction, or what if the electrode is here and current is going here? So it will take the resultant vector, right? It will take the resultant vector, that from this angle how much it is moving, right? So, or if the current is going like this, so this will be the vector, right? This will be the vector. Over here, what's happening is more current is over here. The direction for some time it goes like this. and then it goes for the left ventricle and the right ventricle. So when it is passing through the interventricular septum, though the current is passing, but this is on a fast track and this is on a slow track. So that's why the current which is passing, so resultant current is as if it is going back. That's why this small deflection of Q. It is because of the difference in the electrical conduction system of the different tissues of interventricular septum, because it itself is pretty thick. So, but not every time it happens, right? Depending upon the slight adjustment of the electrode, Q at times might be missing. So you might get it something like, and straight away like this. Right? So that is why when it is calculated, right? So it is calculated at its lowest level over here, at its lowest level. So that is what is called as the PR interval, which is, yes, you are right. It is, in fact, it should be named as PQ, but well, whatever it will be, it is, reality is PQ, right? But will named as PR interval. There are many other reasons also, but now we have understood that this is the distance which we are supposed to measure. So in this case, if we say that, okay, over here and over here, right? So this is one small squares calculate 1, 2, 3, 4 and 4.5. Right? Definitely less than one big square, right? Definitely less than one big square, because R is over here and this is somewhere over here, right? So this is 3, 4 small squares roughly. So that is the PR interval. Now we go back. I'll show you the ECGs, which will be having very clear concept, right? It will be definitely more than 5 big boxes, so there won't be any point of doubt. Okay, so now we know how to calculate the PR interval. So initiation of the P wave, right, and the distance traveled. This is the Q. So we are interested in this distance and this. So this would be our PR interval. PR interval. It should be less than 200 milliseconds. So in other words, from the ECG, less than one big box, right? Less than one big box. So now in case of type 1 AV block, in type 1 AV block, only one thing happens, that on ECG, right? It is on ECG, right? PR interval is more, right? Is more than one big box. But think for a second, if it is more than one big box, so what is happening? What is happening? From SA node, it comes to AV node, it is taking more time, because this is the point when the atria is contracted, and when this thing, if it elongates, it means the journey, the trouble is from SA to AV. It is taking more time, right? It is taking more time. Important is that PR interval is more than one big box. I'm writing it in capital with no dropped beat. No dropped beat. Because if there is beat drop, just excuse me for a second. I'll be right back. Yeah. So coming back to this, there should not be any drop beat, right? So in which cases, what could be the cause? Why it should really occur? So these are the causes. First thing, as the age increases, right? As the age increases, and if the heart is not conditioned properly, this is a sign of aging because of fibrosis. So whenever it is fibrosis, so they are not a very good conductor, so it slows down, right? Or athletes. In case of athletes, because there is increase in the vagal tone, right? There is increase in the vagal tone, and we understood that vagus nerve, right? Vagus nerve stimulation. That is what happened. It slows down the SA node, right? So because it is slowed down, so it will be affecting the AV node also. So that's why it can lead to this increase in the PR interval, because the whole thing has been slowed down. Important things to know about. Say one, that is the drugs. We'll not go into the detail of the name of the drugs, but one important drug, that is calcium channel blocker. Calcium channel blocker. Why this calcium channel blocker? We know this reason. Here it is, affecting this area. When the calcium channels are blocked, the speed at which the calcium should really enter into the cell, that is slowed down. When it is slowed down, it will be taking more time. When it is taking more time, so that's why the conduction would be slowed, so PR interval will increase. Right? So this is calcium channel blocker. Also the beta blockers, but that is what we'll discuss later. Fourth, it could be normal. It is what is called as a normal variant. And it can be a normal variant. Another important thing is, in case of, say, coronary artery disease, now see the variation. Some things are totally normal, some things are good. Let's say in case of athletes, in some case, you need to take the history whether the patient is on this beta blocker or the calcium channel blocker. You need to figure out that is there any pain associated coronary artery disease is there or not, or if there is involvement of mitral valve, right? All these things, or important thing, you need to go for even the lab test in the form of electrolytes. So electrolyte imbalance. This is that topic which will be coming again when you'll be into your final MBBS. Right? So any of the mitral valve surgery, it happens. So when you'll be into your final MBBS, we'll be discussing the whole thing exactly, but with that how to take the history. What are the things which you'll be asking? So here the electrolyte imbalance, nothing, no history. You need to go for the lab test. Right? You'll be going for the lab test, two major lab tests, whenever it is. It is the magnesium and the potassium. These are the two things which you'll be taking. And in such case, whenever the potassium is less, so you do expect, because see, the potassium is less, right? So that is what is called as the hypokalemia. Right? It is hypokalemia. Or when the magnesium is less, so it is called as the hypomagnesemia. Right? Such varied reasons. So that's why you'll be ruling out these reasons with the history. That's why history would be playing a major role, right? So when you are asking, it might happen like patient will say, why so many questions? But one simple, from the looks you figure out that patient is pretty fit, right? Just ask for this, taking any drugs? No. And the history is that patient is regularly exercising, running, so that means you look like, yes, this could be because of the increased tone. So that's how you'll be ruling out. So that's why all these reasons are to be into your mind. Now, this is at times incidental finding. Incidental finding. Incidental finding is patient has come for fitness test. Increased vagal tone. Increased vagal tone means when the vagal nerve, that is stimulated. Right? Vagus nerve is a nerve which is a 10th cranial nerve. It supplies all the way from, starts from brain and all the way it comes down up to the pelvis. Right? So this is a parasympathetic system. Rest and digest. So when it is stimulated, do you know that in parasympathetic system what happens? It will say, heart, you take rest. Right? So how will you tell the heart to slow down? Because SA node is slowed down. You'll tell the SA node that don't fire fast. Heart will slow down. So that's how this system really occurs. Say for example, very interestingly, we talked about this last time. Vagus now passes via this mediastinum. So when you inspiration, when you breathe in, right, the vagus nerve is stimulated because of these lungs, because lungs, they will be expanding. So when this is stimulated, actually you'll find that heart rate slows down, okay, with the inspiration. When there is expiration, so lungs collapse. So now this vagus is not stimulated. When vagus is not stimulated, that means SA node picks up, right, and the heart rate is increased. So these are normal variations, right? Increase and decrease. So that's why our heart rate, it keeps on changing. If you are wearing any of the sports watch, so you'll find that it is never exact same, right? Even if you are not moving still, there would be minor variation, 2-3 beats up down. It will keep on happening. So that is because of the vagal tone or the vagus nerve. So we were talking about that this could be an incidental finding. Just as such, you took the ECG and you found that it has. But one vital thing is these patients, if you have found this, follow-up is vital. Patient has got no symptoms, so don't underestimate it. Because such patients, those who are having block, type 1 AV block, there are 3 times they are more prone for atrial fibrillation, right, which is a killer. Atrial fibrillation. So keep this thing in mind, that don't neglect. Right? Because say for example, many of the things are like temporary. Normal variation, yes, nothing can be done. Electrolyte imbalance, just correct those electrolyte imbalance. But see in these cases, coronary artery disease or mitral valve surgery. Sorry. After that, you are watching that on ECG, this PR interval is 300. Right? Now it is a point of concern. Patient is right now fine, but keep in mind that it can get worse. Right? So that's the reason that follow-up would be of very much importance. Okay, let's fast forward and move on to see this. Watch this. Forget about this at present. Right? Just watch this lower one, which is the 25 millimeters per second, which is a normal speed. Right? Above one is a double speed. This is a normal speed. In this normal speed, this is our P wave and this is our, take it over here. This is our PR interval. You'll find that yes, beyond doubt, it is more than one big square. Right? It is more than one big square. Correct? Got it? From here to here, definitely. From here to here, from here to here. So definitely it is more than one big square. But continuous beat is there, right? 1, 2, 3, 4, 5, 6, 7, continuous, right? There is no drop beat. So what is drop beat? Let's see this, right? I'll explain that this is not type 1. This is another one. We'll see that. But here, one cycle, second cycle, third cycle, missed. One cycle, second cycle, third cycle, missed. This is what is called as the drop beat, which is occurring at a regular interval. So when we'll be learning clinics, when we'll be taking the pulse. So pulse, which is said that we take the pulse with the help of 3 fingers. So when it is said that the pulse is regular, right? And if it is irregular, so then there will be 2 things. Whether it is regularly irregular or irregularly regular. Right? So we'll study this. But over here, this is what, at every fixed distance, there is irregularity. Every fixed distance, there is irregularity. So this is regularly irregular. Regularly irregular, right? Or over here, that is said for pulse. Over here, it is said for this, that this is dropped beat. Dropped beat. So in type 1, what we understood is that there is no drop beat. Right? The moment there is drop beat, the entire diagnosis changes. So there is no drop beat. Right? This is continuous. At times, you will be running the ECG at a faster pace. Right? The paper is moving at the speed of 50 nm. So in that case, now when you calculate, so this is because the paper is moving at double the pace. So now you will be calculating how much? 2 big boxes. 2 big boxes. This was one of the questions. So over here and over here. Yes, it is type 1 because see 1, 2, 3. Yes, now it is clear. It is more than 2 big boxes. So we are dealing with, and there is no drop beat. And another thing is, all are of same distance. So PR interval is same. So PR interval more than 200 milliseconds. Right? So this would be more accurate, 200 milliseconds, which is in normal case 1 big box, and if the speed is double, the 2 big boxes. Right? So that's why 1 big box. When the speed is double, the 2 big boxes with no dropped beat. With no drop beat. So this is what we are dealing with. The easiest one, the type 1. Over here, see this and this. Yes, it is less. Right? It is less because this is normal. Okay. So this is done. Type 1 is done. The easiest one. Moving on to the second degree AV block. Now this second degree AV block, its name is Mbbs. It is also called as the Mbbs AV block. 2 type of, it is called as the Mbbs 1 or the Mbbs 2. Mbbs 2. That's how it is in the ECG report. It would be mentioned like this. But if you want to go in detail, this is what is called as the Bankim and this one is hay. But otherwise, type 2 Mbbs 1, type 2 Mbbs 2. So these are the two types. So first, let's start with Mbbs 1. In Mbbs 1, again we are dealing with the PR interval. But over here, PR interval is very specific, and that is progressively longer. This is where at times you might have to take a running strip. Progressively longer. So you measure one PR interval, you measure second PR interval, you measure third PR interval, and you find that it is increasing. Right? This is one point. The second point, drop beat. There would be a drop beat. Right? So this drop beat, it is also called. So why beat should drop? This is SA node. This is AV node. So AV node is telling SA node has said do the work, done actively. Again it is telling do the work, done. Again it is say do the work, doing. And then do the work, not responding. That is what is called as a non-conducted beat. Non-conducted beat. So here the mechanism is like, this is the keyword. There is progressive fatigue. That SA node is getting, that AV node is tiring. There is progressive fatigue of AV cells. That's the reason. That's the classical reason behind this. Right? Progressive fatigue. And in which condition can it really occur? Well, it can occur in almost all the conditions which were mentioned into the type 1. But one of the important is when you see this, and if the patient is of myocardial infarction, so then this is very much seen in inferior, right? The base, inferior wall myocardial infarction. This is one. It can be in very rare cases, but it can be a normal variant. Or because of the extremely high vagal tone, vagal nerve, right? Increased stimulation of the vagal. Drugs, same drugs, right? But over here, the dose has increased. So calcium channel blocker, if you find that yes, patient is taking calcium channel blocker, decrease the dose and this thing will go away. Right? But the most vital thing when you are going for lab test, type 1 Vancomycin, right? Type 1 Vancomycin, type 1 Vancomycin, this one. This occurs when there is increase in the potassium. So do remember this. Right? This is what is called as the hyperkalemia. Lab report is important because of this. So you see the ECG, you see the lab report. Sometimes it happens like you see the lab report and you still get the ECG and you figure out this. So over here, there would be progressively increase in the PR interval. Let's see this. So let's start with the PR interval over here. This. We are calculating small boxes, right? So this is how much? 1, 2, 3, 4, 5, almost 6 boxes. 6 small boxes. Calculate next one. This. Clearly you can see, right? These are 1, 2, 3, 4, 5, 6, 7, 8. 8 boxes. Let's see further. This. Clearly 5 over here. This is 6, 7, 8, 9, almost 10 boxes. 10 boxes. This is. And then moving further, here is the P wave. Where is the QRS? Absent. So this is a drop beat. Fulfilling both the criteria. So yes, we are dealing with type 1 Mbbs, also called as the Bankim, and this is type 2 AV block. Correct. In type 2 AV block, this is the main type. This is the subtype, type 1 Mbbs or the Bankim. If you want to say something more, so you can say one more thing in this. Normally, it is said that this is cyclical, right? At every regular interval, it is happening. So, what is the ratio? The ratio, which is asked, PQRS ratio. So, 1 wave, 2 wave, 3 wave, and then the drop. Okay? So, at every 4P, there are 3 Q waves. So, this is what is called as the 4:3. Right? 4:3, P is to QRS ratio, and this is type 1 Mbbs with a drop beat, right? Type 2 AV block. Which ECG? This one. Here, you are talking about this particular ECG. Okay. See, 2 things which we have to see. One, PR interval is what we have to check, right? PR interval. And this PR interval is gradually increasing. Right? It is gradually increasing. So when PR interval is increasing, so here it is, the first PR interval, right? The first PR interval, there are 6 small squares. In this, from here to here, there are 8 small squares. From here to here, there are 10 small squares. See, even if you just watch it like this distance, this distance, this distance, right? Visually, right? It is increasing, right? It is increasing. So when it is increasing, and then there is a drop. Then there is a drop. This is classical type 1 Mbbs. Got it? So this is what is called as the type 1 Mbbs. You have to just watch for gradual increase. So let's go back to this part. What will you do? Now see, when the heart is getting slowed down, vagal tone didn't get it. Which vagal tone? Because see, vagal tone will do what? Vagal tone will decrease the conduction speed, right? It affects SC node, it affects AV node. So it is because of the vagal stimulation. That's what we mentioned over here. Increased vagal tone, right? Vagus is what? Vagus is slowing down the whole thing. Any of the slow conduction of the heart thanks to vagus. Got it? So in the treatment part, if the patient is having bradycardia, his heart rate is slow, and you take the blood pressure, there is hypotension. There is hypertension. So in such cases, use atropine. You took this decision from the ECG. You took the blood pressure also. and you find that yes, this is, if the patient is taking say calcium channel blocker, right? Patient was, so in that case you need to decrease the dose. So this is first step. Ask the history, patient is taking any of the AV blockers like calcium channel blocker, beta blockers, etc. So in that case, decrease dose of AV blockers, that is calcium channel blocker and the beta blocker. But what if it is not effective? If not effective, other drugs are there which can be tried, but otherwise you need to go for pacemaker, because this condition can worsen very fast. So we need to go for pacemaker. So pacemaker, there are two types of pacemaker. One which will be affecting specific upper heart, right? There are specific pacemakers which will be affecting upper as well as lower. So we'll be discussing pacemaker as a separate topic, right? Where I'll show you all different type of pacemakers. But that's what we need to do. And in pacemaker selection, which pacemaker to be selected, that purely depends upon that what is the condition of the heart. Right? What are we talking about? Which condition we are talking about? Okay. Our next topic now is type 2 AV block. And in type 2 AV block, we are dealing with Mbbs 2. Mbbs 2. Mbbs 2, which is also called as the hay. Right. So this is type 2, or also called as the second degree. Right. It is also called as the second degree AV block. Now in this case, it is very typical. Again, we are dealing with the PR interval. PR interval is constant. PR interval is constant. And on top of it, there would be intermittent drop beat. Intermittent drop beat. Over here, over there, first degree heart block. In the second degree heart block, that is type 1. What did we say? We said that this is becoming progressively longer and the drop beat. Correct? Progressively longer. While over here, this PR interval, this is constant. And then there is a drop beat. So again, we'll be going for the ratio. Say for example, P is to QRS complex. So that could be say 3P with 2 QR or 1 QR, whatever, right? So let's see some ECG. So over here also there is P is to QRS ratio, right? That ratio is over here also. Let's see. See this. This is for a very good clarity. Here to here. First degree AV block. So here to here. Here to here. Yes, it is more than one big box. It is more than 200 milliseconds. Right? So we are talking about first degree AV block. But just now we said that here it is, here it is, here it is. Not necessarily say PR interval is more than 200 milliseconds. Not necessarily. It is more than 200 milliseconds in AV block first degree with no drop beat. Correct. No drop beat. In second degree, we saw that there is progressive increase. So just here, right, this distance, here, this distance, here, this distance. Yes, is consistently increasing, and then there is a drop beat. So clear, this is Mbbs 1. See this? So when you see a drop beat, just visually you see that this distance, this distance, this one, this distance, this distance, this one, this one, this one. It's same, right? When it is same, we are dealing with Mbbs 2. And we are dealing with Mbbs 2. We'll just go back to that with the reasons. But that's how you'll identify. There is drop beat in both of them, rank back or hay, in both the cases. But over here, PR interval is progressively increasing, while in this case, PR interval is constant. We'll come to this just in a minute, because that is a variation and it's very interesting. So that's what we were talking about, that there is intermittent drop beat. This is dangerous. When we are talking about this Mbbs 2, right? In one word, we will be telling it Mbbs 2. Right? When it is Mbbs, automatically it is the second degree AB block, and in that it is type 2. So here we said that it is a PR interval. Right? It has got, and it will be having a fixed ratio. It would be having a fixed ratio. The ratio can change in case of Mbbs 1, but over here in Mbbs 2, it is absolutely a fixed ratio. Fixed ratio of what? P QRS. So it can occur like 2 P waves and 1 drop, right? So this thing will 1 and drop. So here 1 P wave, 2 P waves. So we have got 2 P waves and there is 1 QRS complex. And the whole cycle will keep on getting repeated. This is what is called as the 2:1. Or it could be 3:1. Right? 3:1. So 1 P wave and QRS dropped, and multiple drops. Right? And it goes. So what would be the importance? When you see such type of thing, that consistent P wave, right, and then there is QRS, go for the QRS measurements. Is it wide? The wide QRS, because QRS can be a narrow or it could be wide. As we are going slightly in more detail, but if it is wide, then the trouble is below bundle of His. That's where the pathology is. What type of pathology? Myocardial infarction. The tissue is damaged below, right? Below bundle of His. And when it is narrow, QRS complex is very narrow. Right? In most of the cases, and almost 75% of the cases, you'll find that the QRS complex is wide. Only in 25% of the cases, and you'll find that QRS complex is narrow. This means your focus should be that this is the trouble which is within bundle of His. Bundle of His. Causes. Why it can really occur. Whenever there is structural damage. To the heart tissue. So either it could be because of, say, myocardial infarction, or if there is development of any fibrosis. So these are the cases in which it will typically occur. So that's why Mbbs type 2, when you find, so that is much risky. right? So there is a structural damage. Importance. This would be symptomatic. Very rarely it would happen like that. It will go asymptomatic. And what type of symptoms it can? Syncope. Syncope is patient suddenly becomes unconscious. You'll find that patient is very tired, fatigued. He might be having chest pain. Death can also occur. This is very high, right? I'm writing it like this. Extremely high risk of progression. It can worsen. Now see, when it was gradually increasing and beat was missing, we were not this much alarmed, right? But when this is happening, right, this is more. Solution? Temporary to temporary, right? Temporary pacemaker. Then later on, you decide that what other types of pacemakers you really want to, right? And I'm writing it in red. Atropine, you will not give. Because if the atropine is given, it can lead to complete heart block, third degree, which we'll be discussing now. So it can go to third degree heart block. So that's, in one case we were giving atropine and it was quite good. In another case we are not giving it. Right? So we saw this, right? That it is same and the block. What type is this? What type is this? You won't be able to differentiate between whether it is Mbbs type 1 or 2 when the block is 2:1 block. Because 2:1 block means one normal P, QRS, P block. Again, P, QRS, P block. So with every 2 P waves, there is one Q wave, 2:1. Right? But is the PR interval increasing? That's what I'm telling you. We can just take a decision whether it is one Mbbs type 1 or Mbbs type 2. Mbbs type 1 means it should steadily increase. But when we say increase, so we need at least 2 PR interval, right? Tab pata chale ki, this is less and this is more, then we can stamp it. And over here, we need at least 2 in case of Mbbs 2, right? When they are same. But over here, in our hand, this is this, right? And then second, no idea, dropped. So in this case, we'll not say whether it is type 1 or whether it is Mbbs 1 or Mbbs 2. We'll just say this is a second degree AV block with 2:1 block, and it is to be treated like Mbbs 2, more serious. Right? It has to be treated like that only. But when in ECG, sometimes you'll see that second degree AV block, and in the bracket it will be like 2:1. Never ever it would be mentioned that whether it is Mbbs 1 or Mbbs 2. Right? It cannot be differentiated. This was one of the questions. Now, you must have noticed that the questions which they ask in exam, they are conceptual. They are not tricky. Right? They are quite conceptual. So if you understand it, you'll be able to figure it out very easily. So now we move on to the third degree block. I'll write third degree block here, and then we'll see the ECG. So this is the third degree AV block. Now, third degree AV block is easiest to identify, in which this is SA node, this is AV node. AV node is shut. AV node is totally shut. It is not sending anything. But what about the atria? Atria will be cool, right? They will be beating without any problem. But what about this ventricles? Well, AV is not functioning. So then this rest bundle of his, right? Left bundle, right bundle, those Purkinje fibers, they'll take over. So they'll start beating in their own rhythm. So here, the upper heart is beating with one rhythm and lower heart is beating with another rhythm. Correct? This is what is called as the AV dissociation. Atrioventricular dissociation. This clearly is an indication that AV node is totally blocked, right? Fully blocked. So there is no association between atria and the ventricles. So that is, there is one typical thing. The junctional, it is called as junctional, or this is ventricle, so it is called as the junctional or ventricular. Remember the word escape rhythm. Escape rhythm. Ventricles, they have escaped from the AV, right? And they are beating in their own rhythm. So that's why it is, this phenomena is called as the junctional or ventricular escape rhythm. Achha. How will it really look like? This is now you see. First, we'll focus only on P wave, right? Here is a P wave. Here is a P wave. Here is a P wave. Here is a P wave, right? You'll find that these are the P waves. But what about QRS? That's the QRS. That's the QRS. That's the QRS. No association. Right? Everyone is beating in their own way. So when you don't find any association between this P and the QRS complex, so that means you are now dealing with what is called as the AV association or the third degree AV block with junctional escape. With junctional escape. In such cases, pacemaker, right? You need to go for pacemaker. There is no other option, right? So pacemaker is compulsory. So you must have seen that things are easy to understand, but जब सब कुछ इकट्ठा होगा, right? When it will be like everything will be mixed, so then even such basic thing becomes complicated. That's why keep revising. These are high yield topics, so keep revising, right? Every few days, that what was in 1, degree 1, what was in 2, what was in 3, and what was that Mbbs 1 and Mbbs 2. I'll put into our shared notes, I'll put some of the ECGs for practice. Right? I'll put some ECGs. And those ECGs, it is not so that every ECG will be having, no, we don't use in type 3. Atropine is not used. So those ECGs, you'll find that at times some of the ECGs will be normal also. Right? So I'll be putting a combination of it, multiple ECGs I'll put. And say it would be like, it would not be discussed over here. Let's say I'll be putting 15 ECGs. So all you need to do is send a mail to me, right? 1, 2, 3, all the way up to 15. And you will write an ECG report. That means, what are your findings? What are your findings? What is the PR interval? Right? What is the PR interval? What is the heart rate? Right? Is it regular, irregular? And do you find any pathology in it? And I'm telling you, say for example, P pulmonary, right? If it is like this, so then that is P pulmonary. do mention it. If you find that, yes, it looks like, say, Mbbs 2, then if it is Mbbs 2, then you'll be also writing PQRS ratio. Okay. And whatever we have discussed, we have understood that whether there is ST segment elevation, right? ST segment elevation, so that means it is a case of infarction, or there is ST depression, so it is a case of angina. All those things, right? You will write per ECG. Right? Try to do this thing so at your ease, because 15 ECGs, it will take some time, but it will be a reasonably good practice. Right? So yeah, individually you will be sending a mail to me. I'll check it individually, and in case if there is any error, so I'll reply also. Okay. So by tomorrow or max by Saturday, I'll put all the ECGs. I won't be putting, yes, one thing is clear, the ECGs will be crystal clear, right? There won't be any doubt. I won't be putting something like this, no. It would be clearly whether it is a first degree block or second degree block or third degree block, ekdam clear. So, right, a clear diagnosis. So if you have understood things properly, you will be able to give this diagnosis very clearly. And if you solve these 15 ECGs, then I'll give you more. Got it? So we can find the ECGs. Same. Say in cardiology, right now all the PDFs are there. So I'll make one folder like ECG for practice. Right? This is the name which will go. And in that there will be individual images, or I can put it into the form of PDF, and then in one PDF I'll do that, right? I'll combine in just one PDF so that you have to download just one PDF, and in that page wise there'll be 15 pages. On every page there will be one ECG. So I'll put it over there. So what I was telling, once you do this now, and I'll find that yes, you are doing it enthusiastically, I'll give you more. Initial, so this would be like round 1, and will be round 2, 3. Later, when you'll be good in it now, I'll start giving you some complex ECGs. Right? So within, it is a matter of you just watch 100 ECGs and you are master of it. You then never forget. And it would be a very prestigious thing, and you yourself will feel so good when in real life you see the ECG and you say something. Watch what happens then. Right? No one would say you are in first year. Okay? So done. How many of us are here? 23. No problem. At least 20 people. I should get 20 emails. Don't worry if you are wrong, right? Make an attempt. I don't want that everyone should be going with 100% of accuracy. Galti hoti hai, hone do. That's how you learn. But do attempt. It should not happen that I do all these exercises and then I'm getting 1 or 2 emails. Because only few students, they even speak or they reply. So that should not happen. Because that will kill my motivation. Okay. So study this. I'm putting this file right now. So thank you so much, and see you next time. Next time we'll be going for more complex, the third part of cardiac arrhythmias. Right. So that would be the final part. So take care and see you day after tomorrow. Thank you and bye-bye.